this was at a time when the Nigerian government information, everything, gave us a maternal mortality ratio of about 800. So that's always been that disparity. What we also see here, for example, is that when you see 1,100 there for Nigeria, and you're talking about sub-Saharan Africa, you look at the fact that this was in 1990 and 2010 compared. In 1990, African sub-region had 850 per 100,000. By 2010, it had decreased to 500. So there has been significant. What I want you to note here actually is the Latin America, North Africa. You find out that North Africa by 2010 we are talking about 78 per 100,000. Latin America we are talking about 72 per 100,000. And yet Africa, sub-Saharan Africa, we still has above 500. Now talking about the distribution within Nigeria itself, that gives you a ratio of about 800 per 100,000. So that's about 53,000 women dying per annum in Nigeria. What is said is that worldwide you have about 340,000 women dying, and you have about 53,000, so that's automatically more than 10% of them. And now we went to the regions and found out, for example, that you find out that there is this inequality expressed. Northeast, 1,549 women, 1,504. In the African region was about 1.7% per annum, whereas West Pacific had about 5% per annum. Southeast Asia had 5% per annum. Hence, you talk about Malaysia, you talk about Sri Lanka, and all those people who actually attained the MDG. And of course, when you even this out, and you're talking about 2.3%, you understand why the whole world, we cannot say the whole world attained the maternal, the MDG goal. This again shows us the trends. For example, in 2008, the NDHS in Nigeria actually said that we had 500 and we had 500, what was it now? 545. We had 545. Incidentally, again, the World Bank thought it was 840. By 2010, it said it was 630. But you will be aware, for example, that there have been a lot of social upheavals, particularly in the northeastern part of Nigeria and all that. And so they have escalated that. By 2013, like I said, we had 576 per 100,000. That's the NDHS. Unfortunately, 2015, we are told 814 per 100,000. That actually is what the whole world is reckoning with. Now, wrapping up on the MDG era, you find out, for example, that there's a significant reduction, about 34% reduction from 546,000 in 1990 to 303,000 in 2015. This was 2.3% per annum decline, whereas we needed about 5.5% per annum to be able to achieve the Millennium Development Goal, which we did not. Now, to achieve the SDG goal, which is to achieve less than 70 per 100,000 by the year 2030, we need to be doing about 50 per 100,000 reduction in maternal mortality ratio in Nigeria. Currently, what we have is about 21.7. So you know that there is a major challenge, because if we go at this rate, there's no way in 2030 that we will achieve even the Sustainable Development Goal. That's just that thing. So, of course, we all know that in 2015, the agenda transforming our world was at it. So the SDGs combined economic, social, and environmental dimensions, which the thought were the major issues that you needed to move the world forward. And so SDG have 17 goals, 169 targets, and 229 indicators. The specific one is actually SDG 3. SDG 3 includes 13 site targets. They cover all the major health priorities, including, of course, the unattained MDG goals, and then non-communicable diseases, mental health, injuries, environmental health, and all. Now, 3.1, target 1 is by 2013 reduce global maternal mortality ratio to less than 70%. Like we said, Nigeria needs to be, we're now having anything from 40,000 to 53,000 deaths per annum. We need to be doing about 3,000 per annum in 2020 to achieve the Sustainable Development Goal. So, what are the causes? Whichever way you see it, you see that about 1/4 of this is caused by hemorrhage. And it's also important that within the first 24 hours, that's where more than half of all these women die. So it's actually peripartum. So what factors are responsible for this? This is the delay that we all know, delay in seeking, delay in accessing healthcare, and then delay in receiving healthcare. Now you find out, for example, that the first delay, lack of information, inadequate knowledge, and danger signs in pregnancy, during labor and after pregnancy. Cultural practices that restrict women from seeking healthcare, perceived quality of care, previous experiences, you had an obstructed labor, you had a cesarean section, and the dead baby, of course, you attribute it to the cesarean section. Next time, you are not going back there. So satisfaction with outcome, satisfaction with service staff, attitude. You know, we don't have respectful maternity care as at yet, and because of that, a lot of women are turned off. Second, delay, distance to health facilities, poor roads and communication network, no transport, no money to pay user fees, poor community support, and if we're talking about the third delay, of course, we're talking about facilities not open in 24 hours, poor infrastructure, no electricity, no water, no telephone, inadequate skilled birth attendant, inadequate equipment, stock out of essential obstetric drugs, no blood, looking for blood at 2 a.m. in the night, strike in Nigeria if it's not Johesu, it is the doctors or residents and all that. So, and then poorly staffed facilities, poorly equipped facilities, inadequate management, delayed or incorrect treatment. I deliberately put this picture. And you notice that in 10 years, between 2003 and 2013, where we had 3 NDHS assessments, you had just minimal for antenatal care. You had just an increase from 58% to just 61%. For facility delivery, just 33 to 36%. And of course, for delivery assisted by skilled birth attendant, just from 35 to 38%. So you know that nothing, the rate of DAKAR has been insignificant. So why do we have it? I got this multi-indicator chart, courtesy of Professor Tuko here. And it's interesting. I just want us to look at some of the states where the indices are the worst, and then they're just placed against one of the states in the south or your state. What you will notice, for example, is that I'm going to look at maternal mortality rate. Look at Sokoto, 2,151 per 100,000. That's recent. And when you compare that to your state that has 262 per 100,000. But the indicators that I'm going to use actually fertility rate. You find out, for example, that while your state had fertility rate of 2.9, Sokoto has 7.3. Why we're talking about level of women who completed secondary education, you find out, for example, that Oyo State had 17.2, while Sokoto had 2.1. You find out, for example, that of women who delivered in health facilities, in Oyo State, 74.7. Sokoto at 4.7. So you can automatically see what are the indicators that led to the high maternal mortality rate. So what are the solutions? What are we going to do? Harrison KA published something in those days before and that's 22,000 consecutive deliveries in Zaria, and that was far back then. And what did they find? They found out, for example, that maternal mortality ratio with education and ANC was 250 in Zaria over that period. And that's almost 30 years ago. And yet they found out, for example, without education and ANC, 2,900. So automatically you see the effect of education. So you know that if you had universal basic education, you know how much it will impact on this. These are the from 2018 to 2022 National Strategic Development Plan, which are these 5 pillars. It puts all the things that are going to be done and all that there. Now, all these programs, you find out that universal health coverage, which is a hallmark or a key in the SDG, would promote access, reduction of out-of-pocket expenses, and incidentally, Nigeria is one of the countries in the world with the highest out-of-pocket expenses for health, and you know that actually encourages poverty. So at the end of the day, there is reduction, poverty level if there is universal health coverage. Of course, introduction of life-saving skills into curriculum, the midwife service scheme, integrated maternal newborn child health, roll back malaria, save me 1 million lives, task shifting, save motherhood, making pregnancy safer. So you see the array of all these programs and all that, but integrating them is actually the issue. And that's why, for example, development of protocols on maternal health interventions, capacity building, infrastructural development, introduction, which is actually what our society stands for, is introduction of maternal death review, MPDSR, which we shall be talking about, and then the volunteer obstetrician scheme. I presume that if, for example, the Safe Motherhood Initiative was revisited, and instead of the 6 pillars, you just put 2 other pillars beside it, which is universal health coverage and perhaps also basic education, we probably would have achieved what we wanted. And more importantly is political will. Hence, for example, the federal government of Nigeria set up now to do an accelerated reduction of maternal mortality in Nigeria. But without that political will, I'm sure that we'll be going nowhere. The rationale for action is very clear, is that there is that wide disparity, and according to Professor Mahmoud Fatala, it's important that maternity is special. Society has an obligation to make it safe. All women have a basic human right to be cared for and protected when they undertake the risky journey of pregnancy and childbirth, and society has an obligation to fulfill this. Safe motherhood is a human rights issue for which countries should be held accountable. Maternal mortality is beyond numbers and statistics. These are young women in the prime of their lives who die at a period of expectation and joy, leaving behind children and families in real need of their care, and of course, again, perpetuating poverty. I thank you for your attention.
About Nigeria, the fact that we have a very high maternal mortality rate, neonatal mortality rate, and under 5 mortality rate are all very high. And that there are indeed a lot of initiatives that are ongoing to reduce these embarrassingly high figures, and that a number of stakeholders are on board, including SOGON, Society of Gynecology and Obstetrics in Nigeria. So what I'm going to be talking about today are the efforts of SOGON, a number of us here, a number of our teachers here, a number of our senior colleagues who are actually worked to institutionalize MPDSR. We know that the lifetime risk of dying from pregnancy-related causes in Nigeria is high, just as maternal mortality is also very high. In fact, the risk of maternal mortality, dying from pregnancy-related causes in Nigeria is only higher, or rather lower than just 2 countries in Africa, being Chad and Sierra Leone. But it's even lower than the sub-Saharan African average ratio of 1 in 36. And that is quite embarrassing, looking at the resources that Nigeria has compared to other countries in Africa. The first speakers actually presented about the SDG. We have this very serious target, reducing global maternal mortality ratio and also preventable deaths of newborn and children under 5, because Nigeria has a major contribution, like the first presenter said, about 10% of global maternal mortality. So actually, this goal of reducing our maternal mortality to less than 3,000 lives annually by 2030 is a major target. And we all know that really there are so many efforts that are ongoing, and that indeed there is a reduction in the deaths of women and children, but it's so slow, and it will be decades. The way we're currently going, it will be decades before we achieve our 2030 targets. And apparently, new methods are needed, including improving the quality of care available for women and children, and that is the whole focus behind MPDSR. Now, MPDSR by definition is continuous surveillance that links health information system and quality improvement process from local to national levels and includes routine identification, notification, quantification, and determination of the causes and avoidability of all maternal and perinatal deaths, as well as the use of this information to respond with actions to reduce further deaths in the future. So what are the principles of MPDSR? Qualitative in-depth review of maternal and perinatal deaths aimed at recreating the clinical scenario, and most importantly, identifying avoidable and remedial factors that led to the maternal and or perinatal death so that they can be prevented for another patient in the long run. So it involves continuous surveillance from local to national level. It's a systemic thing, and the main thing is to identify these causes of the deaths and use this information. And then most importantly, this information needs to be disseminated to policymakers, civil society, health personnel, so that everyone is aware of the magnitude of the deaths and what can be done to prevent further. So it's a form of medical audit. Most importantly, there's no blame and no confidentiality has to also be maintained. And the most important thing about it is that it's a cycle, so that it's as a quality improvement initiative. It's meant to improve the care. So having established what is a standard of care, one looks at it, compares with the practice, and then identify the incoherence, define the change that is necessary to achieve this standard of care and implement that change. And then we'll continue on and on, so that along the line, there's improvement in the quality of care available. So we know that there are many types of medical audit, including verbal autopsy, MPDSR, near-miss review, and confidential inquiries to maternal deaths at state and national levels. So let's, like I mentioned earlier, there's the MPDSR actually can be from the point of view of the facility or even at the community. And at the facility level, there are a number of members of this MPDSR committee, which includes the chief medical director and other important members of the hospital, which are supposed to meet from time to time. And this is actually a chart which I borrowed from the Federal Ministry of Health training slides about how the facility level MPDSR is actually conducted. If there is a new maternal or perinatal death, the case file is supposed to be collected within 24 hours by the MPDSR officer, and then the maternal death file is compiled, or the perinatal death file is compiled, or both, depending on the type of death. And then there's completion and dispatch of the death notification form through the office of the head of facility to the disease surveillance notification officer in the local government. And then this is followed later by filling of a clinical case summary form. And this is to be done within 72 hours. And then when the MPDSR meeting of the facility holds within the period of 2 to 4 weeks, that case and all other cases of maternal and perinatal mortality are supposed to be discussed. And it is those forms that are brought forward, and grid analysis of this clinical case management is done. Case analysis summary is written, and then recommendation and action plan grid is also completed, because that's one of the forms that are also completed. Then the MPDSR secretary writes a session report, and then this is completed and dispatched through the office of the chief medical director to the Federal Ministry of Health. This is how the facility level MPDSR is conducted. And this is the term of reference of the facility level MPDSR committee, identifying all the deaths, notifying the local government, ensuring that these forms are completed, and hold regular MPDSR meetings so that all deaths that occur in that facility are discussed in a non-threatening manner, and to compile a report and recommendation for local staff and the hospital, and to prepare a standardized report that is then sent to the state MPDSR committee and follow local recommendations to ensure that they are implemented to improve the quality of care. This is the Federal Ministry of Health notification form, which is filled once a death is identified. This is the maternal one, there's also a perinatal one. And then this is the health facility-based maternal death review. The form is much longer than this. It is in these forms that all the details about the death are recorded, including contributory factors, so that the deficiencies, the things that can be improved next time are also identified. And then this is the response tracking form, quarterly summary report, where all the deaths are supposed to be recorded and forwarded to the federal and state committees. And then there's also the community-based maternal and perinatal death surveillance and response. This is aimed at identifying all maternal and perinatal deaths at the community level, including those that died on transit to hospital, their follow-up analysis on their prevention. And this is centered on the use of verbal autopsy to source information from relevant persons and to reconstruct the events leading to the death of the deceased and their determinants. And this obviously requires the cooperation of the community and families. And there's also a community-based NPDSR committee that has this term of reference to identify the deaths, to investigate, and make recommendations and action plans to prevent recurrence of the deaths and track the implementation. And there are a number of community-level members that form this committee, chaired by the chairman of the Ward Development Committee, and the secretary is the head of the local health facility, which could be the primary health center or the dispensary, etc. Now, this slide actually shows the community-based level NPDSR. It involves first notification, because when a maternal or perinatal death occurs in the community, someone has to identify and notify the authorities. And this committee, some members of the community-based NPDSR are supposed to visit the family and console them, and then most importantly request for another day to come back to hear exactly what happened. So on a later date, the investigation of the maternal and perinatal death is carried out using verbal autopsy by this committee that I earlier showed within a specified period. And they're supposed to identify someone in the community who knows about the death and what happened, and then the verbal autopsy is conducted with that individual at a later date to try to identify what the factors that led to that maternal and or perinatal death. And then reports are made and actions brought out to reduce this maternal and perinatal death. There is also a state-level steering committee on NPDSR, which is supposed to be chaired by an obstetrician and co-chaired by a pediatrician. So all the states are supposed to have these committees, and yes, a number of states have them. It also includes professional associations as members of these steering committees, including SOGON and the Pediatric Association of Nigeria. And they are supposed to actually be planning and establishing NPDSR at all the health facilities in the state, and to also hold regular meetings to review all maternal and perinatal deaths in the state, and also synthesize the data, analyze it, write a report, and recommend to the state government what needs to be done to reduce maternal and perinatal mortality based on the findings that are coming into that committee. And then there should be dissemination of these results and advocacy to improve what the deficiencies that were identified. There's also a national NPDSR steering committee meeting with a nominee of the Honorable Minister of Health, who is supposed to be the chair, and another co-chair, and heads of various important units and co-ministries that are relevant to reduction of maternal and perinatal mortality in Nigeria. There's also an NPDSR desk officer who has the responsibility to compile all the various forms that are coming in from the various state governments. And this committee has a similar term of reference with that of the state level committees, planning and establishing NPDSR in the country, regular meetings to review maternal and perinatal deaths, analysis of the data, a recommendation to the Honorable Minister of Health on national efforts for reduction of maternal and perinatal mortality, disseminating this result, and advocacy for the improvement of maternal. So, NPDSR can contribute indeed to the attainment of the Sustainable Development Goals, because it is a means of notifying and collating accurate data on maternal and perinatal deaths in the country, including the numbers, causes, and contributory factors. Analysis and interpreting this data, including trends, risk factors, demographics, avoidable factors, and then most importantly, use of this data for evidence-based changes, which is aimed at further reducing this maternal mortality. This could be in the form of health education, improving referral services, policy changes, systemic improvements, improvement of the human resource for health, and so on and so forth, depending on the finding. And these findings are supposed to be disseminated to policymakers, civil society organizations, professional associations, monitoring and evaluation to ensure that these changes are made and to further refine and improve on these changes. And advocacy based on the findings so as to improve resource allocation to maternal and perinatal health and other systemic improvement. With all this, MPDSR has indeed a very big role to play if it is implemented as supposed to be and as advocated from beginning by someone. And the end result indeed is that it can lead to reduction of maternal and perinatal mortality, which is a major point in the Sustainable Development Goal. I want to thank you very much for listening.
This is the map I was talking about, the work map of maternal mortality. Those that have figures above 300 maternal deaths per 100,000 lives are in this dark green. And I said, unfortunately, the whole of West Africa is in this dark belt. Of course, some part of Southeast Asia, the Latin American countries. And I said, this same map can be used for belt of poverty, belt of hunger, belt of disease, belt of death, and all of that. We are not going to bother ourselves as to why the women are dying, why our mothers are dying, but the reasons have not changed. And we are told, aside from those obstetric complications, there are social, economic factors, the delays. What is interesting, I think, at this level is to say that as obstetrician, really, we do not need to wait to this third level before we make our impact. Ideally, this is where we are trained to. But in our small little ways, we could do some advocacy to the community in terms of recognizing disease conditions. We could also support the referral system, whether by providing mobility in form of bicycle, motorcycle. So before now, I used to think that this is where we should belong. We should wait for them to come, and then thereafter we should put our skills to practice. But I think each and every one of us can still do a little here, and more significantly, that level. Yes, we've had various interventions or initiatives to reduce maternal mortality. The Safe Motherhood Initiative since the, I think, 1987 or thereabout, skill attendant and delivery, the emergency obstetric care. Fortunately for us in Nigeria, at least, we've been credited to this initiative, this midwifery service scheme. It was so effective. Unfortunately, along the line, there were policy somersaults, and therefore, I'm not too sure if it's as effective as it was 10 years ago. And Senegal was very active in it. But some countries copied us, and I'm told they are doing very well with our midwifery service scheme. I listened to Professor Jamilu talk about maternal death review, which also, if it's properly done, can help reduce morbidity and reduce mortality. I'm to speak to the volunteer obstetrics scheme, which was initiated in our country, and hopefully, if we do it well, that too should reduce maternal mortality. I'm talking about the viewers. It was in Calabar 2010, in a symposium like ours, like the one we're having now. I'm not too sure why I was made a speaker, either because my friend was the chairman of the scientific committee, Professor Etuk. Is that the reason?
Yes.
Oh, that's the reason. So I was made a speaker to talk about delays at the third level. And in my conclusion, I had added this, that if every obstetrician in West Africa adopts one health facility to render voluntary services, maternal mortality in the sub-region will reduce significantly. That was in 2010. And much later, I think 2 years later, under the leadership of Dr. Fred Achel as the president of our society, we had a conference, again, Chris is aware of this, one of these maternal death review we did in Abuja. And then we had some, I thought the idea of Calabar 2010 can be put into writing. So I sent him in a proposal, and we communicated by email. By our annual conference, the Sogon of 2012 in Abakaliki, there was a presidential session, and I was invited to speak more to the topic. A year later, or in fact 6 months later, the Sogon had signed a memorandum of understanding with the National Primary Healthcare Development Agency to formalize the concept and see if we could have initial support. Then we were told by the Senegal president that various sectors should try and do these viewers. The center, I think Lagos has always led until recently. I think the northern sector has taken over from Lagos now. But the president of Senegal is not looking at me. But by 2014-2015, Lagos sector had extensive experience with the volunteer obstetric scheme, and that became our guide nationally. And from their experience, we had to put documents together, present to the Federal Ministry of Health in Nigeria, and there was a formal launch. By this time, I think Professor Brian Adima had taken over as the president of SOCON. And it was a big ceremony. That was in July 2016. You can see our president. It looks more like a world press conference during the launch of the viewers. What is important is that there was need to formalize the program, the scheme, so that we do things in uniform and document things properly. So this document was produced, guidelines for the volunteer obstetrician scheme, and with specific objectives that include provision of mentorship to healthcare workers, visit and provide support in maternal health services, especially in the form of antenatal care, delivery or postnatal care, at least once in a month in whichever facility that was chosen for the scheme. And then we're to perform on-the-job training as needed during the visit, and so many other objectives. But we also developed a selection criteria so that you just don't jump into it. You must be a medically qualified doctor with specialist training in obstetrics and gynecology. You must have shown interest in the VOS program. You should be registered with council, and of course, I think towards the end, another condition was added. You should be of good standing. I don't know what that means, but at least you pay your dues to SOGO. Then there were terms of reference for uniformity. One amongst this is the strengthening of the referral system. And there was need for us to also document properly our activities at the various sites, so that for statistics, for reference, for evaluation, for monitoring. These are some of the terms of reference in it. And of course, there were deliverables which included the list of preferred cases and names of referral hospitals, so that as you visit those sites, at the end of the month, you should tell us the number of patients that you've been able to refer from that rural site to a bigger site, amongst others. Of course, we had a lot of partners. You said a lot guidelines. This is how the logbook look like. Whatever activity you do, you need to document it in the logbook for record purposes and for data analysis. In the next 3 minutes, I will share with you my own personal experience. I've shown these slides at, I think, the Senegal conference in Akure, where if the site chosen is very appropriate, then it will be difficult to reach. And this, I think this visit was during the rainy season. By the time I came close to my site, it was impossible to drive a small car like this, but I didn't know. And then I had to negotiate with the bicycle rider if he would take me further, and he agreed. And you can see how the environment is. I was able, if you look posteriorly, you see the miniature signposts of the health facility, and you can see the neighborhood. Eventually, we got to site. There were a lot of challenges, both environmental and medical. And the battles were many. I had to choose the one I wanted first. And I felt, I felt the place too should be properly identified. So this was the signpost that I met on arrival. Within 3 months, I struggled, and we got this. And we had to put this so that they know that this is a courtesy of the Sugon viewers. And of course, there were many other issues, the delivery bears and all of that. It was easier for me to do that than the regular visit, because you must even put in some basic structure before you start doing antenatal care. So the environmental issue were my first priorities, and thereafter we have fought along. And I cannot end this discussion without highlighting some of the challenges expected if you choose an appropriate site. The first one is to get the authorization letter, especially if it's a public facility, to reach it. Yes. And of course, then as you come into the system, some of the health workers will be worried. Who is this gentleman? What has he come from? Is the intention as neat as he claims? Just volunteer? You know, so it takes time before they accept you properly. And if you're not careful, the hostility may even make you change your mind. Of course, security concerns are issues, especially in the present Nigeria. And if you have other functions, then there will be competition within the voluntary of the social scheme and the other functions that you may be performing. So you need to find time for it. So in conclusion, Mr. Chairman, sir, the voluntary of social scheme was proposed as our collective response as substitution to the unacceptably high maternal mortality in Nigeria, which I think we can extend into the whole of the West African sub-region.
Yes, all the presenters. It starts with a little bit of emotion because it makes us think of Nigeria. And the President mentioned education. Education required, thanks to you. And we use this opportunity to express our gratitude to all our teachers. So that said, education can also permit us to ask intriguing questions. The one I want to ask is, when the President of Senegal, in his concluding remarks, he made allusion to the political will. Can you permit me, sir, what charisma have you used in Nigeria to influence this flow that awaits us, and which is still there? Because the aim is to borrow. Some of us come here to steal. We are not official thieves, but we are academic thieves, and thieves of vision too. So we might want to know what qualities you have and what you have used to convince the government, and what impact you have made as the President of Senegal, so that we can carry that over.
My specific question has been partially answered by past President Ogedengbe, which is that for the last 20 years, sir, the maternal mortality has really not changed in Nigeria. And one of the major challenges she has brought out is that education is the key. But we have also noticed, and you have also alluded to it, sir, the President of Senegal, that education is on the decline in the north. What are we doing as Senegal to address that major challenge? Merci beaucoup.
Creating partnerships. We are not yet there, but we are actually really running and making sure. So one of the things, of course, as soon as a government comes in, a minister comes on, you are partnering with them, you are making yourself relevant, and then we're doing things so that when you talk about outreaches and all those things, the visibility is there. So those are the things that we use to make it obvious. And there's nothing really done. When we talk about the audit, maternal death review that we just discussed, it was actually SOGON. It was a SOGON initiative, and the National Council on Health had to adopt it before other professionals were involved. So you understand the fact that we keep trying to bring all these things to the fore, and we're hoping, and like you said, it's not easy. In Nigeria, when you want to go to television or something, usually they ask you for money. So even if you want to talk about the health of the people, you really find it difficult. So it's trying to negotiate and navigate around that and finding sponsorships and finding partnerships. That's been the weapon that we're utilizing in several areas of our activities. Thank you very much. Education is on the decline, like you said, and it is very difficult for SOGON to actually bear his chest and say that we are going to pioneer improvement of education in the northern part of the country. But identifying the fact, I just said that Harrison et al. That long time ago found out, for example, that amongst the educated with antenatal care, only 250 per 100,000 was achieved, and we're talking about over 30 years ago. Whereas amongst those who are not educated, in the same subset, the same community, you had 2,900 per 100,000 maternal mortality ratio. So the difference is so significant. There is nothing, education. Of course, you need to establish peace. Thank God for countries like Senegal, where we are today. Maternal mortality has been really on the decline. Ghana is another country, but then you also find out that it's because of peace that's been maintained. So where you have insurgency, you have communal clashes and all that, usually education is on the decline. And we said something, we said that it's inversely related to Human Development Index, which is a function of life expectancy, education, per capita income. So there is no doubt about it that those things are important, but then also the Minister of Education, the Minister of Health in Nigeria today is a gynecologist. We are hoping that we continue to maintain visibility by pushing our members. Some of us are trying to go into the Senate. I'm sure you are aware that some gynecologists are going to the Senate, and we've on several platforms also solicited for support. Those are the people, actually, I say that as doctors, we micromanage. But politicians actually are the people who macromanage. And the earlier we join them to macromanage, we continue to stay at table doing cesarean section and not actually minimizing maternal mortality. Thank you.
Us have to follow them for monitoring and evaluation.
We were doing that before.
Well, we are doing that. Maybe it's an expanded form of it. The volunteer element is where you, without compulsion, decide to, amongst other competing variables, to select a site and decide I will go once in a week, fortnightly or monthly. Just as we go to watch games, we go to preach. So that is the type of volunteerism we are talking about. And the intention is not that if we are 100 and 99 of us will start immediately. Those moved by the Spirit will start first. And I'm sure very soon prophesied the asylum from this outreach station will be moved by the Spirit and go to not just Bombom, isn't too sophisticated, not Panshi, maybe one road area in Barikin Lad. I think, thank you very much, sir. So please, there's a slight difference between the outreach we do for rural posting and the genuine volunteer missionary journey that we're talking about. Thank you very much, sir.
A situation in Bia where you need a lot of manpower. Okay, let's just talk very briefly about it.